now continue with our GIT from first aid. We reach the intestinal atresia. So a little bit about intestinal atresia. What is intestinal atresia? Atresia is basically a complete obstruction or complete or partial of the part of intestine present at birth. So basically, the baby cannot pass intestinal contents, and this leads to early vomiting and abdominal distension. Now, the clinical presentation is key here because whenever you have bilious vomiting means that the vomiting is green. And this means that the obstruction is distal to the ampulla of water. Now, the ampulla of water was the opening through which the bile and pancreatic secretions were entering the duodenum, right? So, if an obstruction is distal to that opening, the bile is going to mix up with the intestinal contents, and whenever the vomiting is going to occur, it's going to be green because it's going to have all those secretions, and that's going to cause an abdominal distension also. And the symptoms which appear are basically within 24 to 48 hours of life, and there's almost always a failure to pass meconium, so baby cannot pass its stool, right? The first thing is duodenal atresia. What is duodenal atresia? During development, the duodenum becomes temporarily solid, right? So during development, the duodenum becomes solid, but then there is a recanalization of that solid cord stage. I told you what recanalization is when we were doing the kidney part. Recanalization is basically you have a solid stick, right? That's your solid cord. But then you have to make that stick hollow. So you have to create a pipe out of a stick. So you have to make it hollow. Something can pass through it. That's called recanalization. Now, the failure of that recanalization in duodenum basically leads to a persistent blockage. And what do you see on an X-ray? You see I'll tell you something that normally you have a bubble. Can you see this here? The gastric bubble. This gastric bubble is normal. It's part of the normal anatomy, right? So whenever you have a duodenal atresia, you have a bubble 2. Why do you have a bubble 2? Because bubble 1 is a normal dilated stomach, right? Can you see this double bubble? So bubble 1 is basically a normal dilated stomach. The bubble 2 is because the proximal duodenum is dilated and there is no gas beyond that dilatation. Why is there no gas beyond that dilatation? Because it's obstructed. This duodenal atresia, you can remember with the D, Downs also starts with the D. It's very highly associated with the Down syndrome in trisomy 21 basically. And also it's very highly associated with the annular pancreas. When we study the annular pancreas, you'll know what that is. Basically, it's a little ring of the pancreas that grows around the duodenum and leads to obstruction, and we'll see later on. And then we have something called as polyhydramnios. Polyhydramnios is when there's a lot of amniotic fluid in the mother's womb antenatally. So this is associated with Down syndrome, annular pancreas, and polyhydramnios. So an example, pearl would be that there is a recanalization failure of the duodenum, which leads to duodenal atresia and a double bubble sign on the X-ray. Similarly, we have a jejunal and ileal atresia also. When you have jejunal or ileal atresia, the mechanism is it's a little different. The jejunal and ileal atresia is basically caused in utero a vascular accident. So if there is any disruption of the mesenteric blood supply, this will lead to the atresia of the jejunum or the ileum. So it's different from the duodenum disruption, okay, because this jejunal and ileal atresia will be caused due to some in utero vascular accident. So while in the womb some vascular accident took place, it caused disruption of the mesenteric blood supply, and that leads to ischemic necrosis, or it leads to resorption of the bowel segment, or it leads to a discontinuous bowel. And that's not a recanalization problem, right? So in jejunal and ileal atresia, there's disruption of mesenteric vessels, typically the superior mesenteric artery, and this leads to ischemic necrosis of the fetal intestine. There might be a segmental resorption of the bowel segment, or there may be a discontinuous bowel itself. The X-ray may show a triple bubble sign where you see a dilated stomach, a duodenum, and the proximal jejunum. And then the colon is gasless. Why is the colon gasless? Because proximal to the gasless colon you have the obstruction. So it can't, that gas cannot move on, right? It's associated with cystic fibrosis and gastroschisis. Do you remember gastroschisis? We just did it here, right? You remember gastroschisis? So this is associated with gastroschisis. It may be caused by maternal tobacco smoking or some use of vasoconstrictive drugs like cocaine during pregnancy. Now, what are the causes of vascular compromise? Basically, it can be maternal tobacco smoking, any cocaine, because cocaine is a vasoconstrictive drug that will lead to ischemic necrosis, or any in utero volvulus. On the X-ray finding, you will see a triple bubble sign. Can you see the triple bubble sign here? You have three bubbles, right? You have the stomach bubble, you have the duodenum bubble, and then you have the proximal jejunum bubble, right? And then the colon is gasless. You can see that the colon is gasless here, right? This is ileal atresia. Again, the colon is gasless. Okay. Now always remember that whenever you have a duodenal atresia, there's something, the duodenal atresia has a double bubble sign, the jejunal or ileal one has a triple bubble sign. The duodenum one is because of failure of recanalization, but the jejunal or ileal one is due to a vascular accident. The timing is important. Duodenal is early within 24 hours, and jejunal and ileal is early also, but this is variable. The duodenum and jejunal and ileal atresia, all of them cause bilious vomiting because it's distal to the ampulla of water. And then the colon gas is absent in both, but remember that the duodenal atresia is highly associated with the Down syndrome, while the jejunal and ileal atresia is highly associated with the cystic fibrosis patients. Okay, moving on. Now let's look at the pancreas and spleen embryology. So basically the pancreas develops from the endoderm of the foregut. Okay, this will be helpful later on when we study the arterial supply or the blood supply of the pancreas. So you must know that the pancreas develops from the endoderm of foregut. Now in the 5th week of development, two buds develop, a dorsal pancreatic duct and a ventral pancreatic duct. This picture is very important in order to understand the embryology of the pancreas. Now, the origin of the dorsal bud, this dorsal bud is basically the posterior foregut, right? And this lies near the bile duct. We'll see how later on. And then we have the ventral pancreatic bud. The ventral pancreatic bud basically, let's go back just one step. The dorsal pancreatic bud originates from the posterior foregut, whereas the ventral pancreatic bud originates from near the bile duct. So you can see the bile duct here. This is the bile duct, and near this bile duct is originating the ventral buds. This is the ventral bud and this is the dorsal bud. The dorsal bud creates the dorsal pancreas. The ventral bud creates the ventral pancreas. Now what happens is the dorsal pancreas goes on to make the main parts of the pancreas, like the body, tail, and part of the head. This entire part of the body of the pancreas, this part is the tail of the pancreas, and this part is the head of the pancreas. But we have another part here, which is the uncinate process. Can you see the uncinate process? So where is the uncinate process going to come from? It's going to come from this ventral pancreas, which is going to rotate and come here. Okay. And the dorsal bud, remember that the dorsal bud also creates the accessory duct, which is the duct of Santorini. So we have an accessory duct here, which is called this duct here, which is called the duct of Santorini. And the uncinate process, this uncinate process or the ventral pancreas creates the main duct. So even though the ventral pancreatic bud is smaller and has less parts that are being made in the pancreas, it's only making this uncinate process. But remember that the main duct, the versing duct, is made by the ventral pancreas. So what happens is, how does this ventral pancreas end up here? Now rotation will happen, right? So rotation and fusion happen. The ventral bud rotates posteriorly around the duodenum and fuses with the dorsal bud. So it goes around the duodenum posteriorly and fuses with the dorsal bud. So both buds contribute to the pancreatic head and the main pancreatic duct. So the main pancreatic duct, the versing duct, comes from both of the buds, the ventral bud and the dorsal bud. But the accessory duct, the Santorini duct, only comes from the dorsal duct. Okay. Now, remember that the accessory duct, the dorsal pancreatic duct or the accessory duct, opens at the minor papilla. This is important. So now we have, since we have embryology, we're going to have some congenital anomalies. Now, what happens is sometimes you have an abnormal rotation of the ventral pancreatic bud. When there is an abnormal rotation of the ventral pancreatic bud, we have something called as the annular pancreas. Okay, so how do I show that to you? Let me post a picture here. Yes, can you see this? So this is a normal can you see that the upper image is a normal? This is the common bile duct, this is the duodenum, and this is where you have the pancreas. Now this is the annular pancreas, where this is the common bile duct, this is the duodenum, but all around this duodenum you have some pancreatic tissue. Can you see that this here, this is only yellow, the pancreas is sitting right next to the duodenum, but here somehow all of this yellow tissue surrounds the duodenum. Now what happens is that there's an abnormal rotation of the ventral pancreatic duct when it's going all around the duodenum. This forms a ring of pancreatic tissue around the second part of the duodenum. So this results in duodenal compression and narrowing. And what happens is in neonates you have non-bilious vomiting and feeding intolerance. And in adults you have abdominal pain and postprandial fullness. So as soon as they eat, there's a lot of fullness because here you have narrowing, right? There's some compression and narrowing. This is associated congenitally. This is associated with polyhydramnias and Down syndrome. So the annular pancreas encircles the second part of the duodenum and leads to obstruction. Now there's something called as pancreas divisum. What is pancreas divisum? Let me show it to you. So can you see here that in pancreas divisum there is a failure of fusion of the ventral and dorsal ducts. So this occurs around the 7th week when there's a failure of fusion here. So what happens is that most pancreatic secretions drain through the minor papilla. Why? Because there's a failure of fusion. Apparently both of them were supposed to contribute to the main duct. But since there's a failure of fusion here, most of it is going directly into the minor papilla. And since this is a smaller opening, the ductal pressure increases. When this ductal pressure increases, it is usually asymptomatic, but since there's a lot of pressure here, this leads to recurrent pancreatitis and chronic abdominal pain. It's the most common congenital pancreatic anomaly. Okay? So let's read what's up here. In the pancreas area, we have pancreas, which is derived from the foregut. The ventral pancreatic bud contributes to the uncinate process. Both ventral and dorsal buds contribute to pancreatic head and main pancreatic duct. Annular pancreas is when you have an abnormal rotation of the ventral pancreatic bud, forms a ring of pancreatic tissue, encircles the second part of the duodenum, may cause duodenal narrowing and vomiting. It's associated with Down syndrome. Then we have pancreas divisum, which is very common, by the way. It's the most common congenital anomaly in pancreas. It's when the ventral and dorsal parts fail to fuse at the 7th week of development. Common anomaly, very common, I told you, mostly asymptomatic, but may cause chronic abdominal pain and or recurrent pancreatitis. Now let's look at the spleen. Okay, when we come to the spleen, now look at this image here. So when we talk about the spleen, we have this transverse view, right? Now the origin of the spleen is from the mesenchyme. Can you see that this is the aorta, this is the dorsal mesogastrium, This is the left vagus nerve. This is the right vagus nerve. This is our stomach. Then we have the ventral mesogastrium. So this was our dorsal mesogastrium. This is the ventral mesogastrium. This is the liver. And in front of the liver is the falciform ligament. You'll later on see that the falciform ligament attaches this liver to the anterior abdominal wall. Now, okay, so this is something else also. This is the visceral peritoneum, right? And this is all around it is the parietal peritoneum here. So this is the transverse view. I've cut it into two halves, and that's how you can see it, right? Now, the origin of the spleen is from the mesenchyme. Okay, so spleen comes from the mesenchyme area. Can you see that this is the pancreas? And in between you have, so this is the pancreas, and what was this? This is the stomach. So the stomach is lying here, the pancreas is lying here, and then in the middle we have the mesoderm. So the mesoderm helps to develop the spleen, right? Sorry, mesenchyme. So the location of the spleen is the dorsal mesogastrium. Can you see this dorsal mesogastrium here? This dorsal mesogastrium, this is the stomach, and this is the aorta. In between the stomach and the aorta we have the dorsal mesogastrium. So this dorsal mesogastrium is the area where we're going to originate our spleen, and hence it has a mesodermal origin, and hence it's a mesodermal organ. It's not an endodermal organ, remember this. So if it's not an endodermal organ, why does the spleen have the foregut blood supply? Because it lies in the dorsal mesogastrium. In between the aorta and the stomach, it lies in the dorsal mesogastrium. So it gets its blood supply from celiac artery. The celiac artery gives off the splenic artery. This is a classic exam trap. The spleen is mesodermal, but it's supplied from the foregut artery, and the foregut artery is celiac trunk. Remember that. So that is something you should know. Coming back to our little line here, the spleen arises in mesentery of the stomach, dorsal mesogastrium, hence it's a mesodermal organ but has foregut supply. Think, celiac trunk gives off the splenic artery. Now moving on to our gastrointestinal anatomy. Now when we talk about the gastrointestinal anatomy, we have quite a few things here. First, let's see the retroperitoneal structures. When we talk about retroperitoneal structures, these are the structures that are posterior to and outside of the peritoneal cavity. Do you remember the peritoneal cavity I just showed you in this image? So this is the parietal peritoneum. Now all the structures that are lying posterior to the peritoneal cavity are retroperitoneal structures. So injuries to retroperitoneal structures can cause blood or gas accumulation in retroperitoneal space, which is why we should know whatever lies retroperitoneally, and this is important. So retroperitoneal organs lie posterior to the peritoneum. They're all outside the peritoneal cavity. They are fixed and they're not freely mobile compared to intraperitoneal organs. Intraperitoneal organs are the one that are partly from two sides. They are encapsulated by the peritoneum. For example, something that is intraperitoneal is jejunum, right? Okay, so clinical importance is that if an injury happens in the retroperitoneal space, then you get a retroperitoneal hemorrhage, and this may not show as classic peritonitis. The air or blood can collect behind the peritoneum, and you have very subtle signs here, right? So remember, this is a mnemonic sad pucker. The S, everything that is retroperitoneally placed, you can remember it with this mnemonic. The suprarenal adrenal glands, right? And then we have the aorta and inferior vena cava. We have the duodenum, second to fourth parts of the duodenum. Then we have the pancreas, except the tail. The tail of pancreas is a little bit in the peritoneum. Why? Because the tail of pancreas almost attaches to the splenorenal ligament, right? Lenosplenal ligament. So it's part of that spleen's peritoneum. Then we have the two ureters, since we have the kidneys here. Then we have here. So we have the two ureters also. And the colon also lies retroperitoneal. This is part of the descending colon, ascending and descending both. So this is the ascending colon, this is descending colon. And we have the kidneys. Again, since you have the ureters, you also have the kidneys, and we have the rectum. Rectum is also present retroperitoneally. But remember that partially rectum is present, not the entire part. Pancreatic tail is the exception, it's intraperitoneal. So key labels you should identify here is that the aorta is slightly left of midline. The inferior vena cava is just right to the aorta. The kidneys are completely retroperitoneal and posteriorly placed. Pancreas is secondary retroperitoneal. Ascending and descending colon are laterally retroperitoneal. You can see them most laterally, right? So a CT scan here, it's easy to understand how everything is placed. You can see the aorta here, you can see the inferior vena cava here, then the two kidneys are placed here, and this is the descending colon and the ascending colon. So if blood collects behind the colon or the kidneys, always think about a retroperitoneal bleed. Now, very commonly tested is one thing called the primary versus secondary retroperitoneal organs. Which are the primary retroperitoneal organs? It means that they're always there embryologically. So the kidneys are always there embryologically. Suprarenal glands are there. Ureter is there, obviously, because the kidneys are there. Aorta and IVC are there. These are all the primary retroperitoneal organs. But the pancreas is except the tail, right? Except the tail, since it has lost their mesentery with time. So the pancreas is secondary retroperitoneal. The duodenum second to fourth parts are retroperitoneal. The ascending and descending colon are secondarily retroperitoneal. So why this matters is because the pancreatic pain radiates to the back because it's retroperitoneal. The any duodenal perforation may lack peritonitis initially. Initially, it may not show up with peritonitis, but with time it will. Any renal trauma will give you a flank ecchymosis. This is the great Turner sign. And any abdominal aorta rupture will give you a retroperitoneal hemorrhage, and any colon cancer will spread in posterior planes. So this is why knowing which structures are retroperitoneal are very important, and I've spent so much time on this. We now move on to the important gastrointestinal ligaments. This is also very important. Now when we talk about the important gastrointestinal ligaments, we must appreciate some parts here. Can you see that this is the left lobe of the liver? This is basically a dissection image, a preserved cadaver. This is the right lobe of the liver. This is the lesser omentum area and the omental bursa. This is the hepatogastric ligament, because this is the liver and this is the gastric area. So all the ligament in between connecting these two is the hepatogastric ligament. Then we have the body of the stomach, the fundus of the stomach, the cardiac or the cardia of the stomach, the greater curvature, the lesser curvature, and the antrum, the pyloric area, where we studied the pyloric stenosis here. This is the pyloric canal. We did the hypertrophic pyloric stenosis, remember? So this is the transverse mesocolon kept right here, and the epiploic foramen is also an important thing we will see later on, right? So if you can appreciate these, we can move on and study a bit about the ligaments. Now the first ligament is the falciform ligament. Remember I told you a little bit about the falciform ligament? Let me pause here and show you that. So can you see here that the liver connects to the anterior wall to the falciform ligament, right? So embryologically, if you see this, we're going to see it and on gross anatomy also. Now this is the stomach and this is the liver. Now what's between the stomach and the liver? Gastrohepatic ligament, right? Go on and posterior to the stomach. Now posterior to the stomach, here what are we going to see? The splenic artery, right? So this is the splenic artery going into the spleen, and this is the stomach. So the spleen is related to this stomach through the gastrosplenic ligament. And then these are the kidneys, and then we have something called the leno-renal ligament, right? The leno-renal ligament connects almost the kidney area to the spleen area, right? The leno-renal ligament is literally the area in which the splenic artery travels, okay? So let's go ahead and look at the gross, because understanding this embryologically helps us understand the gross also. So, what does the falciform ligament do? The falciform ligament connects the liver to the anterior abdominal wall. As we saw embryologically, what it contains the ligamentum teres hepatis. Sorry, ligamentum teres hepatis. What is the ligamentum teres hepatis? It is the remnant of the fetal umbilical vein. Okay, this is formed after obliteration of the fetal umbilical vein. And also what contains, it also contains some paraumbilical veins, which are part of the portal systemic connections. Okay, that is something you should know. Now, since the paraumbilical veins are part of the portal systemic connections, um, whenever you have portal hypertension, this cord recanalizes, becomes hollow again, and blood travels due to the increased pressure of blood. It travels back and creates caput medusae. Caput medusae are like these spider veins around the umbilicus. Basically, they become recanalized and they show up near the umbilicus. So, ligamentum teres is a key landmark of the liver's anterior surface. Okay, and it derives from the ventral mesentery derivative, right? If I go back to that embryological picture that I showed you, you can see that it comes from the ventral mesentery. So the ventral mesentery gives you the falciform ligament, which is the anterior, the connection of the liver to the anterior wall, and the gastrohepatic ligament. Okay, so it comes from the ventral mesentery, and the dorsal mesentery goes on to give the gastrosplenic ligament and the linorenal ligament, because they're posteriorly present, right? That's just common sense. No extra addition to your knowledge build up. Then we have the hepatoduodenal ligament. This is the most accurate representation of the picture of the hepatoduodenal ligament. So it's basically connecting the duodenum to the liver. This is the hepatoduodenal ligament. What it does, it connects the liver to the first part of the duodenum. So this is the stomach. The stomach ends and the first part of the duodenum starts. What it contains, you can remember what it contains by using the mnemonic DAVE, right? So it contains a duct for D, the common bile duct, right? It contains the common bile duct on the right, and then it creates an artery, DAVE DA. The A is for the artery, which is the proper hepatic artery on the left. So this ligament has a common bile duct on the right, the proper hepatic artery on the left, and inside it has inside posteriorly it has the vein, DAVE DAVE. So it contains the portal vein posteriorly. It also comes from the ventral mesentery, and it's part of the lesser omentum. Can you see how you have the lesser omentum here? So this duodenal hepatoduodenal ligament, becomes part of this lesser omentum, right? One more thing that is important is that clinically this is very high yield, because there's something called as the Pringle maneuver. The Pringle maneuver is when you compress this hepatoduodenal ligament to stop the hepatic inflow bleeding. And why is that? Because the hepatoduodenal ligament contains the portal triad, which was represented by the DAVE, the duct, artery, and vein, the common bile duct, the proper hepatic artery, and the portal vein. So the Pringle maneuver is done to compress this ligament to stop any hepatic inflow bleeding. And also remember that this hepatoduodenal ligament borders the epiploic foramen. This is the epiploic foramen, and this helps to distinguish between any inflow bleeding, basically in the portal vein or hepatic artery, from any outflow bleeding from the hepatic veins or inferior vena cava. Right? So let's look at this. This is derivative of the ventral mesentery. The Pringle maneuver, ligament is compressed manually or with a vascular clamp and surgery in a omental foramen to control bleeding from hepatic inflow source, like the portal vein, hepatic artery, which are basically contained in this ligament, the gastroduodenal ligament, the hepatoduodenal. I keep on saying gastroduodenal, I don't know why. The hepatoduodenal versus outflow bleeding, which is in the hepatic veins or inferior vena cava. It borders the omental foramen, which connects the greater and lesser sacs, and it's part of the lesser omentum. Let me show you the greater and lesser omentum. So this is the lesser omentum. The lesser omentum has the hepatoduodenal ligament, which has the portal triad where we were doing the Pringle maneuver, and it also has the hepatogastric ligament, right? So both these are part of the lesser omentum, right? And the greater omentum is basically a single fold that is comprising of two double layered sheets of peritoneum. So that's the difference between greater omentum and lesser omentum. We now move on to the hepatogastric ligament. Now you can appreciate the hepatogastric ligament. It's also part of the lesser omentum. It also comes from the ventral mesentery. And what it contains, basically, it contains gastric vessels. So it forms the anterior wall of the lesser sac, right? And it can be cut surgically to access the lesser sac. Okay. Then we have the gastrocolic ligament. What it basically is, this gastrocolic ligaments takes the gastric area, the stomach, and connects it to the transverse colon lying in just in front. So can you see that this is your stomach and this is your transverse colon, and the ligament between these two is the gastrocolic ligament, not shown here. It contains the gastroepiploic arteries and it's derived from the dorsal mesentery. Now you can see we're moving inferiorly, and now the dorsal mesentery is present. It's giving rise to these structures, and it's part of the greater omentum. I told you out here is the greater omentum. So all here is the greater omentum, right? So it's part of the greater omentum. It's an entry. The gastrocolic ligament is also an entry point into the lesser sac during surgery. It's important in gastric and pancreatic procedures. Then we move on to the next ligament, which is our basically gastrosplenic ligament, right? Let me see if I can show that to you here. The okay, this is a good picture to show the hepatoduodenal ligament. Remember, it had the portal triad, it had the common bile duct, the portal vein, and proper hepatic artery, and we were doing the Pringle maneuver here in the the hepatoduodenal ligament. Okay, let's look at the gastrosplenic ligament. Now, this is the spleen and this is your stomach. So, in between two, you have the gastrosplenic ligament. The gastrosplenic ligament connects the greater curvature of the stomach to the spleen. And what it contains the short gastric arteries and left gastroepiploic artery. It is derived from dorsal mesentery and it's part of the greater omentum. I told you all this is the greater omentum. Short gastrics are vulnerable during splenectomy. So whenever splenectomy is happening, they take really good care of the short gastric arteries because they're very vulnerable. Any injury here will cause hemorrhage. Any damage here will cause ischemia of gastric fundus. Then you get ischemia of the gastric fundus here if the gastric arteries are injured. Then we have the splenorenal or the lenorenal, right? So the splenorenal here between the kidney and the spleen. Here you can see, can we see the splenorenal here? No, we can only appreciate it here. This is the kidney and this is the spleen. So in between you have the splenorenal ligament. The splenorenal ligament basically is the ligament that connects the spleen to the left kidney, right, and almost to the posterior abdominal wall, because the left kidney is very near to the posterior abdominal wall. So it contains the splenic artery and vein. I showed it to you on the embryological picture also, that it contains the splenic artery and vein, and it's very important that you know that the splenorenal ligament I told you contains the tail of pancreas. This is very important because this is the only part of the pancreas that is part of the peritoneum. That's why we call the pancreas as a secondary peritoneal organ. It's derived from the dorsal mesentery, and the clinical importance here is that the pancreatic tail injury during splenectomy can happen. Why? Because when we're removing the spleen, the tail that is coming into the splenorenal ligament or the lenorenal ligament can be injured, and the pancreatic tail can be injured, and that explains pancreatitis complication involving spleen. So whenever the spleen is involved in an injury, pancreatitis complications are also seen because it's almost inside, it's literally inside this ligament, right? So remember, when we have the dorsal mesentery gives rise to the gastrocolic ligament, the gastrosplenic and the splenorenal ligament, and the ventral mesentery give rise to our falciform ligament, hepatoduodenal ligament, and hepatogastric ligament. So those are your important gastric ligaments. If you want to revise, you can stop the video here and revise.